Hello, good evening, dear, and welcome to your favorite medical show, Ask Dr. Saw. Tonight, as every night, we're bringing you educational and informative programming as it relates to health. Tonight, we will be talking to Dr. Saw about asthma. As you're aware, we did cover asthma sometime earlier in previous discussions. However, tonight, while we are covering asthma again, Dr. Saw has informed that there is an update on asthma. So tonight, again, we will be talking to Dr. Saw about asthma. Doc, good evening and welcome to the show.
So, hi, good evening, Akash, and yes, thanks for having me again.
Wonderful, Doc. We spoke about asthma before, but to refresh on asthma, just tell us again, what is asthma?
Yeah, no, indeed. I mean, as you know, medicine is very dynamic, and everyone always asks me, doctors, you guys never get it right. Sometimes you tell us do this, and then 6 months after you change your mind and you say do something else. How do we know what is right? And I always say that it's a science, and we look at evidence and intervention, and we look at is the intervention working. And ever so often, things are changing. And of course, we need to update our knowledge, update our management, or how do we do things. If the evidence says otherwise, then we make changes to suit the evidence. And that is why I decided that we're going to do an asthma update, because we have a body in the UK called a NICE, that stands for NIC, National Institute of Clinical Excellence.
Okay.
And they usually look at evidence medicine, evidence-based medicine. They look at all the evidence, and then they make recommendations and guidelines. And it's a very reputable organization that, guides doctor as such. How do you do things? How do you manage and things like that? And the British Thoracic Society also, and lots of the American societies also work in conjunction, and they bring out guidelines. So they have just updated their guidelines in November. So I thought, as a follow-on from my previous asthma talk, I can just give a little update. And also, it's never, you never have too much knowledge.
Of course.
So if I can reiterate things and repeat things 100 times, then it sticks with you. So you tend to remember it. And it's the intention. It's for people to have a better understanding of their condition. So your question, sorry.
No, that's fine. That's fine. It's good to have an overview.
Yeah. So the question is, just a reminder as what is asthma. So I have my own definition where I say asthma is a chronic, obstructive, reversible airway disease characterized by bronchospasm. So I'll explain each component here. I'll explain in a bit. Bronchospasm, airway inflammation with increased mucus secretion. So let us start with the definition. I mentioned a few things. I say it is chronic, all right?
Right.
So chronic means it is there for a period of time. So this is, which is acute. So acute means it is short-lived. Chronic means it is something long-standing. It is obstructive condition. It obstructs the airway. So it's an obstructive airway disease, meaning it's caused blockage of the airway. And of course, we know the airway involves you breathe in through your nose, it goes down the lung, and you have the bronchi and bronchioles, that is large and small airways. And it affects both large and small airways. I also said it is a reversible condition. Now that is important. So chronic obstructive reversible airway. So chronic obstructive reversible means it comes and goes.
Right.
It's an on and off condition. So by understanding that definition, then you would see you can actually diagnose it yourself, or not. We wouldn't say diagnose it yourself, but you can have a suspicion when you're affected. So if you get something that, hey, my lung is blocked, but it goes and comes, and it's there for months and years. And I have increased. Then you have bronchospasm mean, so characterized by bronchospasm. The airway has got size,
Right.
and it's made up of muscles and other things. And spasm mean they get tight, they contract. So the airway gets narrow. And then you have inflammation of the airway. Inflammation is when you have, a swollen airway. So it's inflamed, when you have something
Right.
inflamed. And then you have increased mucus production. So we know our airways are lined with cells that produce mucus. And they work for various reasons to bring out all the debris and all the dead cells out of the body, and that's what you bring out and you have phlegm.
Right.
So that's our definition in a nutshell.
Okay, wonderful. Let's talk about causes, Doc. What causes asthma? I keep hearing often that the reason why most people has asthma is because it's hereditary. They got it from somebody else. They got it passed down from something. That's what I hear all the time. But what are the causes?
So I would not say that it is a condition that in totality it is hereditary, right? Because we wouldn't have, if your parents have asthma, means you will have it. So it's not inherited that way. But there is a multifactorial cause, a genetic predisposition. So yes, the fact is it runs in family. So there are different types of asthma. We can categorize it differently, but when we look at the cause as such, asthma is divided into what we call extrinsic and intrinsic. And intrinsic is unknown, meaning we don't know what triggered the immune system, but we know what happened in the body, or we don't know what's the exact cause. And the extrinsic is when there is an allergen that causes a hyper reaction of the airway with increased inflammation. So we know pathophysiologically what happened in asthma. We know that the airway is inflamed and is triggered by some sort of allergen, and that we define as extrinsic asthma. So and they're related, they're families of condition, hay fever and eczema. Hay fever, eczema, asthma, they're related. They are described as atopic conditions. So there's an element of allergen, and allergen can be, different things that stimulate the immune system. And we know that there is an hyperactivity of the immune system that is causing this inflammation and inflammatory response of the airway. So that's the cause as such. And of course, they classify asthma in different, you can have what we call allergic asthma, non-allergic asthma when they can't find an allergen. And then you have what is adult onset asthma, you can have occupational asthma. So there are different triggers. So we look at triggers. Triggers are very important in telling us if this is asthma or not.
Right.
Because by and large, the majority of asthma, they are linked with certain environmental and allergic or immunologic conditions or response.
Right. So when people, some of these signs or some of the triggers, as you rightly say, I remember I'll share something with you, Doc. I remember a couple of years back when I was married then. My ex-wife, who suffered from asthma, she called to say that she was having an asthma attack, and I went home, and what I saw made me froze. She was lying on the bed, panting for breath, and her lips were kind of getting blue, and she had this serious. I knew it was serious. I rushed her to the hospital, but I guess when she called me at the hospital to tell me this was at work to tell me this was happening, I did not know of the seriousness of it. But by the time I got home and she looking that column, perhaps she could have, I don't know what could have been worse.
No. It is a serious condition.
Yeah. What should we look for, Doc?
No, yeah. So I'll tell you the signs and symptoms. But asthma, let me just tell you a little bit about how bad it can be. It accounts for 250,000 deaths annually.
Wow.
I mean, you're thinking about it. 250,000 people will die from asthma annually. They say worldwide is probably about 300 million people affected. In the US, they have about 25,000 people affected with asthma. So, it's a big burden on the healthcare system. Also, is a big burden on patients' health and that. In some societies or countries, you can have, it varies from 1% to 18% in the population. So, it has, and there are lots of factors in terms of environmental factors and triggers that can make you predisposed. In the developed world, it's probably account for about 10% of children affected in the developed world. And that is significant. I mean, you're talking about 1 in every 10 child has got some degree of airway asthma or asthma variant condition. It's significant. But okay, if I say, so you said that what you have just described with your ex-wife, it is scary. Imagine the scariest thing when you go to see someone, they are panting for breath.
Right.
You know that
right.
is life-threatening.
Yes.
So if my airway is occluded, is closed, air can't get into the airway or get out of the airway, then you can't get oxygen, and eventually you can die. So it is not a trivial condition, and despite all this public health initiative and public information, asthma still takes life, so many a year. So what do we get? So we get shortness of breath, because I said that the airway is so the airway, instead of the size like this, you get, so it's inflamed, it's swollen, and then you have mucus production, so you have blockage, things blocking it, and then you have the walls contract, so it's narrow. Do you remember as a child, you used to take a straw and you blow into it, you narrow it down and you blow into it and it makes a whistling noise?
Yes, indeed, yes.
So when the airway gets constricted and it's narrow, it makes a whistling sound. So you have that whistling song comes out as a wheeze.
Right.
And that is one of the hallmark of asthma or airway obstruction generally. So you have shortness of breath, you're struggling to breathe, you have wheezing, that whistling noise. You can cough because there's lots of mucus and irritation of the airway, and you have chest tightness. So the airway gets tightened and you have chest tightness. And of course, if that is not relieved, so you would find that asthmatic generally, the thing about asthma as differentiated from other respiratory conditions, you're okay to breathe in, but it's an obstruction getting out the air.
Okay.
So you breathe in okay, and you tend to go as if normally our lung has got a recoil mechanism that pushes out the air.
Right.
So the air gets trapped in asthma. So you have to make an effort. So you go
push it out. Yeah.
As if you're making an effort to push it out. And if you don't have the air moving in and out, there's a buildup of carbon dioxide in the body.
Yes.
And there's no oxygen getting in because whatever is there is trapped. So think about that. And then eventually, of course, it will send your oxygen level low. It can trigger heart conditions. Your heart can go into irregular rhythm. And eventually, if it is not corrected, you can die. So the signs and symptoms are very, very dramatic, and they're very clear. And you know that. So shortness of breath, coughing, wheezing, and chest tightness. Those are the cardinal features of asthma. Now, how do we diagnose asthma? I suppose that's the question everyone asks.
Well, I want to ask about the diagnosis, and I also want to ask you. You mentioned that that there were some changes in the diagnosis also. So, what has changed from then to now?
Well, traditionally, we used to, and what has changed, and just to pinpoint that.
Yes.
We can diagnose asthma with a blood test.
Oh, really?
So, but I will tell you, there is a caveat to that.
Okay.
In the sense that it's not purely you take a blood test and you say you have asthma.
Right.
But they have included the new guidelines. The new guidelines have included, among other things, a blood test, and then you could say to that patient, yes, I have confirmed you've got asthma. So,
Okay.
majority patients will come in and they say, Doc, I am having, so the history. So whenever you're making a diagnosis, we start with the story.
Yes.
And any condition, the story is important. So we start with the story, we look at the examination, and then we do investigations, and then we make a diagnosis. That's how the natural progression of a disease condition, or you know. Mm-hmm. So the story of asthma, one, you want to hear the story. So what are the things in the story? You would say, the patient will come in and say, I'm having shortness of breath, it's on and off, but there is an important element to it. There are triggers. So they can say, right, when I go out in the garden, I feel my chest is tight. Mm-hmm. When I have my dogs around me, or I go to visit a friend with a dog or a cat, or in the night when I'm in bed, I feel I am having that tightness more. So you have they're called triggers. Then you have something called variability. So I'm just telling you the story.
Yes.
How do you make the diagnosis? Then you have what is called variability. Variability means it changes. So I might be okay now, and then I step out of the house and I get tight-chested. Or I go into a different environment. Or in the morning when I wake up, it is different from in the evening. Mm-hmm. My chest feels different. I feel tighter. My breathing, I get more out of breath. So that is very important, because you will see when I come to the diagnosis, these are elements they take into consideration to make the diagnosis. So we look at the variability, we look at the triggers. There are some occupational asthma where patients would, when they're at work, they get shortness of breath and wheezing, mm-hmm. and when they're home, they're fine. Now that is defined as occupational asthma. That's an important point to note, because there are certain environments that can trigger asthma, and it is defined as occupational asthma. And it is important to highlight that, or to recognize that, because you can make changes to your occupation or your health, to give you a better health outcome.
Yes.
So we need to recognize occupational asthma as a distinct entity. So if anybody say, right, only when I'm on holiday, I don't get this asthma. When I take a break from work, Monday to Friday, I'm having out of breath. When I'm home on the weekend, I'm fine.
Right.
Start thinking, could this be occupational asthma? But okay, so the diagnosis, so if you have the signs and symptoms, so you're wheezing, you're out of breath, you're coughing, chest tightness, there are some variability to it, and there are some triggers. You can then do a blood test. So the guidelines now stated in 2014, NICE, the National Institute of Clinical Excellence, and the British Thoracic Society, they have agreed on doing a blood test to check something called your eosinophil. IgE eosinophil is a component of your white blood cell, and that is an immunologic mediator. So it's something that is in the blood, a type of blood, a white blood cell that is activated when there is allergic or immunologic problem.
Oh, right.
Now, if you test that level and it is high, so that's a blood test you're doing. So you have signs and symptoms, so we code you as suspected asthma, and we run that blood test. We say, and it's positive, that means it is higher than the laboratory reference. I can confirm that you're asthmatic. So that's a new guideline. Now, you can also do a test, a breathing test. And this is relatively new as well, but it's been around for a little while, where you're blowing into something to test your fractional exhaled nitric oxide. So it's a gas you're blowing out and you're testing it. And they have parts per million or billion, mm-hmm. whatever the level is. And if that is elevated, that's a marker of you having a high eosinophil activity. That is, that type of inflammation in the airway. And if you're suspected asthma and you have those tests done, you're confirmed as asthmatic. Oh, so we call that objective testing. Historically, what has changed is that they have put that down as now as step one in the diagnosis. So you have the signs and symptoms and you do those tests, and they're very accessible, and a blood test is so accessible and readily available. And then you could say conclusively, objectively to that patient, you've got asthma. But before that, we used to rely on blowing into tubes, right. And you measure the, how breathing out and the percentage and how much liters per minute kind of thing. And that is called spirometry. It is still being done, but we use now step 2 and step 3 as different tests we move down the hierarchy. Now, a traditional test with what we do is called a bronchodilator. Because today's topic, I want to talk a bit about diagnosis and management.
Right.
That has really changed. Because my original asthma, I've talked about presentation. Now, when you're making the diagnosis, we blow into these tubes. And if my airway is blocked and I can't blow out a lot, I tend to give you an inhaler to relax the airway, and I ask you to blow again. So you blow initially, you see that there's a value, and then I give you the inhaler to take, and I ask you to blow again.
Right.
And if there's a difference about 12% change, or 200 mils, we measure it, and
Yes.
there's a value to that. If there is that change after you have taken that that relaxant, the airway dilator or relaxant, we can say that is asthma as well. So those are objective tests. So the blood test, that blowing out of the fractional exhaled nitric oxide, and then you have that, then the spirometry. And then in extreme cases, they go on, we can do what is called a challenge test, where they give you drugs to tighten the airway, and then we see, then we measure the airflow, and we can find out. But that is usually done in hospitals and secondary care. So that is really the change that has happened in terms of diagnosis. And we have something called a peak flow. I don't know if you've ever seen one. I have one. I was looking for a picture of one. I don't know if you can see this picture. I'll show you a quick picture here of a peak flow meter. So, sorry, here we are.
Oh, cool.
So,
Yes, we can see it. We can see it, yeah.
So you put something here and you blow, and it measures the, so I'll just bring that closer.
Yes.
How much air you're blowing out.
Okay.
And it's a little bit simple test you can do at home, and you'll notice that when you are tight in the chest, the marker moves a little, and when the air is good, after taking the inhaler, it pushes a lot more air out. And those are the tests sometimes we look at to make that diagnosis. Quickly, I know we are running out of time.
Yeah, we got about six to 7 minutes more.
All right. Coming to the management. So this is important. I talked before about a stepwise management of asthma, and
Yeah.
this is very important. Like any condition, you start with the least drug, and you step up treatment. So asthma, they have different steps, 1, 2, 3, 4, 5, 6 kind of thing. Now, in the older guidelines, step 1 used to be defined as a blue inhaler alone. So quickly, as a synopsis, let me just quickly say this. I said to you, you have bronchospasm where there's contraction of the airway. So in treatment now, if you look at the definition, we are giving drugs to attack all three things. So when you have that spasm of the airway, you give a drug, it's called a bronchodilator. Traditionally, that's a blue inhaler.
Right.
Then you have inflammation of the airway. In inflammation, you give a drug to counteract that, and that is called a steroid. Now, instead of giving tablet steroids, you give an inhaled steroid into the lung, so you don't have side effects of the whole body. So it works localized more. And then you have lots more secretions and inflammation, and there are some medication you can give to dry the secretion or to decrease the secretions. So in the management of asthma, these are the little things we need to look at. So traditionally, we used to give, step 1 used to say, use the blue inhaler
Right.
alone in patients who have infrequent attack of asthma. The guidelines changed to say, no, we don't give that as step 1. We want to give a combined treatment in step 1 where you have a dilator plus a steroid in step 1. Because they found that lots of health professionals they're giving patients that blue inhaler, and patients are not getting better, and they are ended up in hospital and even becoming fatal because they are taking too long to take the steroid. So we want to get steroids, inhaled steroid into you early o'clock.
And what color, sorry doctor, what color that comes in? The inhaler?
So the usual general steroid one was the brown inhaler.
Okay.
So what they have done now, they say, okay, in step one, let us use the brown and a different bronchodilator, not the short-acting, the blue. It's called a long-acting. So similar like the blue, but it works for a longer period. They combine that in one inhaler. So you get two drugs in the one inhaler, and they give those drugs together as step one. So even patients with occasional asthma, we will say, have a bit of steroid orally, so you have that. So in the management of asthma, the stepwise management is starting at a low dose of whatever steroid or dilator you're using to expand the airway, and then you build up the treatment gradually until you have, when it's so bad, you have to take steroid, oral steroid. I said to you, we try to avoid oral steroids. We try to prefer to give you inhalers, but if it is so bad, you might have to go on oral steroids for a short period of time. So the stepwise management, we start with the low dose of the steroid with a dilator to open the airway. Then we keep increasing dose of the steroid. Then we add other drugs. There are drugs called like antihistamine family, where they are leukotriene inhibitors. We call them Montelukast, that type of drug, call that. And then we keep adding other types of drugs until you reach steroid. And now there are some new drugs in the market. They're called biologics. Because, as I said, asthma, there are lots of immune response in the body that is causing inflammation. So we are giving immune therapy in the form of injections to suppress the immune system so you don't get a flare-up of your asthma. And that is, a management in a summary. Of course, your doctor will decide where you are. You can start, if you have an acute attack now, I can take you straight to the highest step.
Okay.
For instance, 5 or 6. And once you're better, I drop you down to 1 or 2. Or if you're mild, I start you at 1 and 2. And as your condition gets worse, I just step up 2, 3, 4, 5 like that. So you either go up this step, down this step, depending on where you are. Now, one important point, if we get 1 minute,
yeah, man.
I know we're going to close. Every asthmatic, I say this to patients, always keep a set of antibiotics and a set of steroids. So we call that a rescue pack. So if you can't have access to your doctor, you're having an asthma attack, lots of times you need, if it is very severe, you want to start oral steroid and antibiotics. And these are asthma that are triggered by infection. So patients get cough, cold, runny nose, and fever. We know they're asthmatic. We don't wait for them to get an attack. Once they start having difficulty breathing and their asthma coming on, we call that an exacerbation of asthma. We start them on the oral prednisolone, usually 5 days at a high dose, 40 milligrams for 5 days. And then they will have a course of antibiotics, a week of antibiotics. So they continue their inhaler, they add some antibiotic and that prednisolone, and that is called a rescue pack. So really and truly, that's a lifesaver in patients, especially if they can't have access readily to their doctor. But you don't need to do that if you are mild and you're managing your asthma very well.
Doc, when we started this conversation, you mentioned that that asthma is a reversible medical condition. Can asthma be cured permanently? And just for the sake of time, let me also add this to ask that are there any types of food that someone should stay away from when they have asthma? Or is there some type of food they should be eating more? And what horrible treatment? Yeah.
Okay, quickly, because out of time. Can asthma be cured? The answer is no. Like hay fever, like eczema, like asthma, they cannot be cured, but they can be controlled. Okay. If you're going to cure it, I tell patients, the doctor is not going to cure it. We control it. We give you medication to control it. Your body will cure it. So people grow out of asthma. You see that?
Yes, I hear that all the time.
They can grow out of asthma, eczema, they can grow out of eczema. 80% of people grow out of eczema, 20% go on to have it for life. Hay fever, you can grow out of it as well, because as I said, it's an immune hypersensitivity, hyperactivity, and your immune system changes. So you can have that happening. The second question, food. If there are allergens, so food allergy and atopic condition, that is asthma, eczema, hay fever, they are related. So there are certain food that can trigger asthma. If you're allergic to something, you can have an asthma trigger. So you have to look at, we normally take a detailed history to see if there are any triggers for those conditions, so you want to avoid those things. But generally speaking, the processed food that is high in fruits and vegetable and antioxidant and anti-inflammatory properties, vitamin D, magnesium, there is vitamin C as an antioxidant, they're good for prevention of asthma. So your classic Mediterranean diet is very good for asthma. The processed food and the ultra-processed food and high sugary food, they're bad for asthma. We don't recommend that. And quickly, in terms of herbal stuff, I don't know personally, I'm not a real big fan of herbal stuff, but yes, herbal medicine have been tried. Licorice, there's a plant called licorice roots they use. There are certain other medicinal plants, but the medical evidence, we don't have enough data to support that. And in the medical community. In terms of herbal treatment, I'm not an expert in that. I don't know much about the herbal treatment, but I know things like Ayurvedic medicine has been tried, and there are some people who have got benefit, who have benefited from it. There are some herbal stuff, licorice root, it's a plant root. They said that it helps asthmatic. Now, the medical community, we don't have enough robust evidence to substantiate, and even all the guidelines in the US and in Europe, they do not advocate the use of herbal stuff for asthma. I don't know, I haven't seen any literature on that. So I would think that, there are herbal plants, extract that can help, works as anti-inflammatory, and if we know that asthma is an inflammatory condition, and I would imagine there are some that will help, but then we don't know the downside, we don't know the dosage, we don't know how to use it. All these things are not studied, in a very robust way. So I would not recommend. It's out of my remit.
Right. Doc, look, I want to ask you something. And sometimes it's good to confirm or debunk these things, because I've heard many times people saying that a good thing for asthma is cannabis sativa. Some people say you boil the root, some people say when you smoke. But I'm thinking that if you have asthma, which is already a blockage in the airways, and you smoke, whatever you're smoking, it will cause some problems. So have you heard anything about from?
I have, so there's some medical evidence. So when we look at cannabis, has been in the limelight for, recently.
Right.
There are lots of theories coming out about cannabis and its benefits and so forth, and the medicinal use for cannabis. But I tell you, logically, you rightly said, if you're asthmatic, it's an airway disease, airway inflammation, you're smoking something or vaping something, it is an irritant to the airway. So that vape or that smoke by itself is bad for your asthma. Mm-hmm. And as a matter of fact, in some patients, we would say if they're not responsive to their medication, we would ask them, are you smoking? And we'll ask them to stop smoking, because that can make them not respond to treatment. So it can be bad. But looking at cannabis specifically, the cannabinoids, cannabis has got a component,
yes,
CBD and THC.
THC, yes,
which is the psychedelic aspect and the cannabinoids. So the cannabinoids, a part of it, CBD part of the cannabis, is got anti-inflammatory properties.
Okay.
They've got that, and it can cause some bronchodilation. So that bronchodilation I talked about. Mm-hmm. So I would think that chemically there are some elements to it to say that fine, it may relax the airway a little and take away some inflammatory processes. So when we look at it theoretically, there is an element of that. I don't know if that is counteracted by the smoke itself and causes an irritant of the airway. So I know for a fact that there is no medical guidelines that would advocate the use of cannabis as a treatment for asthma. I haven't come across any of those guidelines in my, part or in my studying so far. So I would think that theoretically there are some elements to it, but by and large, it's not advocated, and none of the guidelines would recommend that.
Brilliant. Before you go, Doc, I want to ask you one question from last week here from one of our amazing fans. Doc, can inhaling hot water and vapor help with sinusitis?
Answer is yes. So we know, when patients have sinus congestion, what do we tell them to do? We tell them to do steam inhalation.
Mm-hmm.
So when we talk about you're congested, you've got mucus, and I said sinusitis is as a result of inflamed sinuses. So the sinuses are lined with mucous membrane. They secrete mucus as in fluid, and the sinus drains in the back of the throat. So the sinus, they've got openings. Now, when you have blockage of those openings,
mm-hmm.
you have congestion of the sinus, and that's when you have more prone to infection because it's not draining. And the treatment for chronic sinusitis is a surgery to open up the sinus and wash it out and drain it. So surgically we can treat it. But if before I go to do surgery, and I will say to you, okay, Akash, why don't you do some steam inhalation?
Right.
You can do Vicks steam inhalation, you could do alcohol, whatever you want to put in there, and create that steam, gets into the sinuses, break up the phlegm and the mucus. It works as a mucolytic, and warm and steam breaks down grease and
right. That's right. Yes.
So the process, so it does work in that way, and it helps. So yes, I would always advocate a little bit of that, but be careful. One time, I'll give you this joke. I had lots of sinus congestion and sinusitis, and I've never done this. This is many, many years back, when I was younger. And I said, okay, my mom said put some Vicks and do some steam. I put a Vicks in the water, warm water, take a towel, cover my head.
That's how I do it too.
Vicks in the water,
yeah.
And I'm breathing in. Now I tell you, I started to cry because the Vicks got into my eyes.
Right.
So if you're gonna cover your head,
you gotta close your eyes.
Vicks, make sure you close your eyes.
Yes, I did. Yes, absolutely. I've done the steaming before, and I can say that it really does help. If you're having you're congested and your nose runny and you can't sleep and all that, you do a steaming for half an hour, man, you like a brand new baby. Doc,
yes.
Thank you so much for the information tonight. Viewers, thank you for joining us, and continue to send your questions, and we will be answering your questions in the following in the next segment of Ask Dr. SAWH. Doc, again, thank you so much for joining. Anything you want to say in closing?
Thanks again, Akash, to you and your team, and to the viewers. Again, I'm grateful for that to support us. And yes, it's all I'm happy again, and thanks. Good night.
Okay, Doc, for the privilege is surely ours here to have someone with your wide range of knowledge in the medical field to share this information with us. So we really do appreciate it, and from all of us here and all the viewers, we want to say thanks to you too. Viewers, thank you so much for joining us, and I've been advocating for safe driving on our roads. We've had too many accidents, and from all of us here, stay healthy. Good night.